we really had a genuine, surgery or life-saving moment with RDI in June 2021, where a colleague had resected a pedunculated polyp, and it had bled significantly. And the problem was that it was in a segment of severe diverticular sigmoid colon, very difficult to expand in a patient who was experiencing quite substantial discomfort during insufflation of air. So you've got a real difficult situation. You've got a patient that's in discomfort, a difficult segment to manoeuvre the colonoscope, and an artery is bleeding. And my colleague had tried for a period of time to try and stop it bleeding, and hadn't been successful. I'd add, he's a very experienced endoscopist. He then called for my help and walked down to the theatre and walked in. And we had a discussion for a moment. And I said, well, you're in one of the rooms where we've got the Olympus X1. Have you put the RDI on to have a look and see if you can spot the bleeding point? And he said, what's RDI? And so I said, well, it's this imaging technique that basically separates the different reds and allows you to visualize the vessels. So anyway, so we nodded, agreed, and went back in with the scope, and went up, turned the RDI on where we got to the pool of blood, and you could see the spurting vessel in the middle of the pool of blood that was completely invisible on standard white light imaging. And then that allowed us to get a clip down through the scope, straight onto the point where the bleeding was occurring. Clip, bleeding stopped, all done. And so after quite a stressful 45 minutes of trying to stop the patient's bleeding, we'd sorted it out in 5 to 10 minutes, just because it suddenly allows you to see where you need to treat. So I think this is a big field change in imaging and endoscopy. This is something that's going to make it more possible to be successful at treating GI bleed, simply because you're not treating it blindly. So I think without RDI in the case I've described, it would be very likely that we'd have tried to go back in endoscopically, and spent a lot of time washing the area and trying just to find where the bottom was. We might have even sort of thought, well, it looks like it's roughly coming from there, and put a clip on out of hope that you might be able to stop it bleeding. But ultimately, if we hadn't successfully stopped the bleeding endoscopically, the patient would have been brought into a hospital bed, and sort of maybe given some tranexamic acid and medical treatment to try and stop bleeding. And if it became evident that it wasn't going to stop bleeding on its own, the patient would have ended up having surgery, which would have meant, potentially a stoma, a sigmoid colectomy at least, or a segmental resection of the sigmoid to remove the point where it's bleeding. So the implications for the individual patient of not successfully endoscopically controlling it were massive.